Well, welcome everyone for joining us today for our second Wellness Wednesday. And my name is Glenda Silva. I am the Deputy Director at Brooklyn Borough Hall. And I want to thank everyone, speakers and visitors alike, joining us today. There are just a few or several ground rules that I would like to highlight. Again, this session will be recorded. Everyone will be muted except for the moderator and guest speakers, who will introduce themselves shortly and speak on the impact of COVID as it relates to their specialization. Prior to this session, we received several questions from constituents, and these questions will be read by my colleague, Mike Wooltall. If you have any questions during this session, please submit them in the chat section, and either myself or my colleague, Mike, or Nate will review the questions and will highlight several from there as well. If you feel that your question was not addressed, then you can email your question to askeric at brooklynbp.nyc.gov. And without further ado, I'd like to share with you a message from the Brooklyn Borough President Eric Adams.
Changing my diet literally saved my life. I'm Brooklyn Borough President Eric Adams. I was diagnosed with type 2 diabetes. I had nerve damage in my leg and my hands and feet. I lost vision in my left eye. I was told I would be on medication for the rest of my life. That is when I researched and learned food was the leading cause of my condition. I changed my diet to a whole food, plant-based diet filled with whole grains, beans, vegetables, fruits, nuts, and seeds. And I reversed my type 2 diabetes. And as we have seen the last few months battling the coronavirus pandemic, health matters, and information is key. That is why I've begun a conversation on health, introducing our Wellness Wednesdays series, featuring doctors from around Brooklyn specializing in general, internal, and emergency medicine, as well as pediatrics. So please come join me and bring your questions. Want to know the best way to access in-person care? When to visit an emergency room and when not? When and how to use telemedicine? When to take your child for routine appointments and vaccinations, and how to do all this during COVID-19. Please take advantage of this opportunity to learn and address your family's health by speaking with a special group of Brooklyn doctors. They are here to listen and inform. And who knows, the information you gain might help save your life or someone you love.
Great. And so now I'd like to turn over to several moderators. My colleague Nate Stravinsky, Jackie Knowles from Brookdale Hospital, and Aneve Dillard from Kingsbrook Jewish Medical Center. Again, thank you all for attending, and please take it away.
Thanks so much, Glenda, and yeah, thanks to the Borough President for his message and emphasis. And thanks to all the team members and doctors from One Brooklyn Health System for generously offering your time this afternoon to engage in this discussion and to share sort of how the last few months have affected your practices and how we can help answer some common questions people have about returning to in-person service or seeking different types of care based on specialty area, whether it's, psychiatry, emergency medicine, general practice, pediatrics, and those sorts of things. And so I want to introduce Jackie Knowles and Ina Dillard from One Brooklyn as well. And then I believe Jackie will introduce the team of doctors, and then we can take off with a broader discussion. Yeah, so Jackie, would you like to introduce the team?
I think she has to unmute herself.
Oh, okay.
Hi, everyone. Thank you for attending this Zoom call with the president. And Nate, thank you. And definitely Enid, thank you for helping me set up this endeavor. As I just kind of gave everyone the heads up, we have 5 of our colleagues provided comments here from OBHS. And in no specific order, I'm just going to go ahead and name, like I say, who you are, your role with us, and your specialty. So the first person I have is Jason Hershberger. He's the chair for the Department of Psychiatry, both at Brooklyn, at Brookdale Hospital Medical Center, as well as at Interfaith Medical Center. And so, welcome, Dr. Hershberger. The second one I have is Dr. Kusum Viswanathan, otherwise known as Dr. Vis, and she is our chair of pediatric medicine, One Brooklyn Health at Brookdale Medical Center. Next, we have Dr. Dari, who is with us. She is with us as the medical director of the Rutland Nursing Home, specializing in geriatrics, internal medicine, and she's again with Kingsbrook. And then we have Dr. Kudroff, who is the Chief Quality Officer for One Brooklyn Health, specializing in endocrinology, and he is housed at Kingsbrook. And last but not least, Dr. Chung, he is the Chair of Emergency Medicine at Interfaith Medical Center. So welcome, and there you are.
Thanks so much, Jackie. Excuse me. Yeah, and now maybe we can have the doctors just speak briefly about a little deeper dive on some of their experience generally, and then just what they've witnessed over the last couple months with their patients, and how they've had to perhaps adapt their practice areas given the new public health situation. Yeah, so Dr. Kadroff, perhaps we can start with you.
I also wanted to introduce Shannon Deveney, who just joined us. She works in our Department of External Affairs over at One Brooklyn Health at One Brooklyn Health at Brookdale Medical Center. So she just joined us as well. I'm sorry.
Oh, great. Yes.
Right. I think you can hear me now. Dr. Kadra, it's a great pleasure to be here. Well, it's been a pretty dramatic 4 months or so, dealing with this coronavirus pandemic. And I think, some of it is just how we managed a lot of very, very sick patients in the hospital. And then in parallel to that is how we, in our own practices, managed even more patients who were sheltering in place appropriately, many of whom have chronic disease. My specialty is endocrinology and diabetes, in order to address and manage their chronic illness during a period of time where our hospitals were almost entirely dedicated to the very acutely ill coronavirus patients. So I think the answer to the question, there's a story in March and April where all our efforts went towards managing people coming through their ID. And we have Dr. Jeff Chung, who's an ED attending chair of ED at Interfaith, probably can give us a lot of information about that experience from an ED perspective. And then how we manage these patients who were home and needed our help. That's sort of an overview of these two aspects, and I could answer a very specific question if there is one.
Okay, yeah, perhaps we can have the other doctors as well just give a brief summary, and then we'll get into some questions. So Dr. Chang mentioned that you're the chair of the emergency department, so maybe you could speak about how that's touched the ED and what you're seeing now as some in-person things are turning on.
Do you guys hear me right now?
Yes.
Yes.
We do.
Okay, so anyway, you know, as emergency medicine physicians, we're well trained for what we call mass casualty events, where, for example, if you have a big fire somewhere, we're ready. We're ready to pick, you know, if you bring in 20, 30 patients at a time, we've been trained to be able to do that. The coronavirus was a very interesting thing for us because this is not something we've trained. It's funny, actually, I was reading a op comment in one of our Annals of Emergency Medicine journals, and one of the attendings really nailed it in the head when she said that the pandemic is really like a slow-moving mass casualty event, where we were ready, but unfortunately, you know, usually with a mass casualty event, you know, you have 20, 30 people that come in. We actually are able to treat them and they leave. And then at the end of the day, it's the amount of people coming in stops. For us, with the pandemic, we actually had to look at emergency medicine a little differently, because it wasn't something that was coming and then it's going to go away. It was something that's coming, and it kept coming in April and in March, even and then in May. And for us, it was a eye-opening experience, because we usually are prepared for mass casualty events, but we weren't prepared for something that would keep our patients and the emergency department for such a long period of time and use up a majority of our resources. We had to adapt during that period of time, where we had to, obviously, one of the most paramount thing for our emergency department was the safety of our patients as well as the safety of our staff. And we had to adapt to say, well, you know, we have patients that come in the emergency department, unfortunately, during the periods of April and May, where it was just majority COVID, but we also had a small amount of patients that were coming in that were non-COVID, and we wanted to make sure that these people were being seen also and safely taken care of. So for us, we had to really change the mindset of how we parsed our emergency department to make sure that these people are not cohorted with these other people that had a possibility of having COVID, and that was a big challenge for us. And of course, and on top of that, we also had a big challenge in terms of getting the PPEs and making sure that our staff was safe and protected. Unfortunately for me, I also had to experience the unfortunate getting COVID itself and having to live through that, and that really was eye-opening for me, because the other side of this of how it affects the staff is how it affects their family, and it affected my family. And a lot of our providers got sick, and unfortunately for us, we also had to figure out how to bring new providers in to make sure that we are taking care of the patients that are coming in from the community. Since the COVID has kind of come down in terms of the volume, now we're seeing the opposite, where, you know, in the news, obviously we were telling people not to come in during the onslaught of the coronavirus, but now we're seeing the opposite, where a lot of patients that usually would come to the emergency department are not showing up. We've seen a lot of decrease in our pediatric population. And I still get it, because when you look around the country, we still see a surge of patients coming into getting sick with the coronavirus. And for a lot of the parents, they're worried. If I bring my child to interfaith, are they going to get sick also? Are they going to contract COVID? And not only are the pediatric cases we're seeing a big drop in, but we're also seeing now a drop of patients coming through that are non-COVID. And even though we have increased, because I'm in charge of the hospital throughput, I actually see the amount of patients that are being admitted also. And we have a higher percentage of admission, even though we're seeing a lot less in volume, they're sicker. And what that's telling me is that a lot of patients are holding off. And a lot of people in our community are saying, you know what, I just have this little chest pain. I'm not going to go to ER because I'm worried that, I'm going to contract COVID. But unfortunately, this is the wrong message. We need to put the message out that, listen, some of these things, some of these diseases need to be taken care of immediately. When you have chest pain, you could have a heart attack. When you can't move a certain part, you could have a stroke. And a lot of the treatment for these conditions need immediate attention, because unfortunately, once you pass a certain amount of time, a lot of the immediate treatment that we can offer these patients are not available. So right now for us in the emergency department, we're living, we've learned a lot from the COVID in terms of how to be prepared when we have another surge of patients. We know how to parse our emergency department to make sure that our department patients as well as our staff is safe. We also obviously know that we have to be prepared in terms of making sure that we have the right amount of PPE when it does occur. The other thing that we would like everybody to put out to the community is that, hey, listen, we understand your concerns about safety, but we also I want you to understand that we want you to be taken care of, and that if you come to our emergency department, the most important thing for us is that we want to make sure you're safe, so you're not going to be sitting in a room with another person who's positive or we think might be having symptoms of corona, and that you are actually going to be in a separate area where most of the time it's patients that do not have do not have coronavirus, and that it's safe to come to the emergency department, and please do come as early as possible, because a lot of treatment is not available after it's too late.
Thank you. Yeah, thank you for giving an overview, and then also just giving kind of a level set on where we are with people who are encountering what are emergency conditions. And maybe while we're on the topic, you could just briefly run through how folks may be able to assess sort of what's an emergency and what some of the basic steps are given where we are. I know for so long, as you mentioned, folks were advised to stay away from hospital environments. And to take some other steps, make a few additional phone calls or engage in telemedicine before visiting a facility. And so I don't know if you have any other notes on that. So you mentioned some of the safety, that it's safe to return to in-person service and their new protocols and kind of partitioning patients or keeping them in separate environments. And a question that came through is that would be similar if you're returning to an in-person hospital environment and let's say you have a pre-existing condition or you are older, and so you may be at higher risk. Those protocols would both apply and protect folks, correct?
Absolutely. Obviously, we look at the clinical picture of the patient when they come in. Age is not really a factor for us. And we've seen young people come in with heart attacks, we've seen young people come in with strokes. So for us, really, when you start having symptoms, you really should seek medical attention and not wait too long, especially for younger folks. And of course, the older folks we worry about because they have multiple comorbidities, and that increase the chance of getting bad outcomes. But even for young people, if you wait too long, it could have been a good outcome, and now you're having some bad outcomes afterwards.
Right. Okay. And then maybe we can move over to Dr. Bhandari to talk just about your experience and your practice area and some notes you might have to share.
Sure. Thank you for having me over. I'm Chief of Geriatrics at Kingsbrook, as well as the Medical Director at Redland Nursing Home. So as a geriatrician, for the audience who want me to define what is geriatrics, it's a specialty for seniors when we cross the age 65. So I see a whole spectrum of seniors from outpatient to homebound as well as nursing homes. So like Dr. Chang and Dr. Kodrov alluded to, someone who deals with palliative and geriatrics, end of life, death and dying is not new to my specialty, but what we saw a few months ago was devastating, to be very mild, to have to put it very mildly. So starting from nursing homes, obviously, we had the visitations of the family members and the loved ones suspended because of concern of bringing the infection into the nursing home. So with that came in, how do we communicate with the loved ones or the community? So we, in the nursing home, did our best with our technology, using Skype, using smart devices to help connect with the loved ones, so keep them abreast with what's happening with their loved ones. We had, as such, nursing homes in the flu seasons have a very heightened infection control practices, and this was almost 10 times over of the infection control practices that we practiced. The regulatory and reporting system of how many COVIDs we have in-house and how many transfers we had ending up into the hospitals and how much mortality was extremely dynamic, and it's in real time, and the expectation is to report this in real time. Also came in after March and April, people who survived, seniors or middle-aged patients who survived, now needed rehabilitation. So we developed a whole new protocol on post-COVID patients who survived, and here they came into a dedicated unit. They got the rehabilitation. They had a very specific protocol for them to heal, and we were successful sending majority of them home, and that was the silver lining with the current status that we were back then. Along with that, just to make sure that we continue to mitigate, apart from the regular practices that all in the community are aware of, wearing the mask, hand washing, etc. We follow the Department of Health guidelines on screening the staff twice a week, until recently when the guidelines eased up and we are screening all the staff who comes into the building. Extremely diligent process, which Dr. Kodroff, is part of it as well. Now we are screening the staff once a week who come into the building, who are in contact with our residents. It could be as simple as a dietitian who are coming in to talk to the residents, or it could be clinicians who are coming in. We are screening them and following it up aggressively. Good thing is we have seen absolutely significant decline in any kind of positive cases in the nursing homes, both in the staff as well as in the resident population. We're definitely not seeing the morbidity or the mortality we saw back in March and April. So we are headed towards the right direction. Coming to community, where we had a compromised senior who was unable to get to the clinics, telehealth came fast forward. Thankfully CMS supported it. It bridged the gap of the provider, clinician, as well as homebound seniors. So we were able to provide that care, talk to the caregiver. Majority of my seniors are not smart device savvy. Few of them are, which is always good to deal with those seniors, but caregivers were invested. They helped us connect with our seniors in the community. We made sure that we handheld them. The challenge was, like Dr. Cheng said, the hesitation to come into the emergency room when issues such as chest pain or such as suspected stroke came up. There was a lot of hesitation, and they were really against coming into the hospital. But that was, again, a lot of coaxing, a lot of hand-holding to convince them, saying, these are life-threatening conditions where we need to seek help. And in the office, a plain day for the month of March, April, and May, I would say until even mid-June, it was the telemedicine took its predominance, again, connecting with them, addressing sick calls, addressing the concerning calls, refilling the medications, etc. So I would say, the offices are open. We are slowly bringing in senior patients who are able to come in with extreme cautious measures of distancing, infection control practices, etc. So that's where we are. We did see these are the most compromised population at the end of the day. Obviously, there was definitely more mortality in my patient population. But I guess, we are coming out of it. We've not seen that kind of morbidity or mortality that we saw back in March and April.
Yeah. Thank you for giving an overview. And I know, folks in senior population nursing homes have been some of the hardest hit groups over this period in New York and across the country. One question we had come through, which applies tangentially a bit is for some parents who are described that they're in their 60s and they've been mostly self-isolating with their adult children, and nobody has presented with symptoms in this environment, and they're wondering, given this period where we are, should they get tested even though they are asymptomatic? I don't know if you have guidance on at this point who should get tested and that sort of stuff. I know the city has expanded that beyond folks who are symptomatic, but specifically related to folks who are 60 plus and then people that they're around.
So, I mean, the scalability of testing has definitely improved compared to where we were in March to now. And if someone who's been in the recommended guidelines, meaning they've not really risked outside the guidelines and they're asymptomatic, it really does not make sense for us to recommend testing. I mean, obviously, even as of this morning, I've had patients who want to do testing, and if it's available for them, so be it. But if there's no symptoms, if they've not been, amongst other than whom they were living with for the last couple of months, and they've practiced what they're doing, wearing the mask and hand washing, and they've stepped out of their home, if that is a possibility for them, then I would say it's not in, there's no strong recommendation for testing on these patients who are asymptomatic.
Oh, okay.
Just to add
yes.
just a comment to what Dr. Bhandari is saying, the prevailing wisdom is that after about 10 or 14 days, there's little or no risk to transmission, with the exception of people that get very ill. But for most people who are ambulatory, if those precautions have been in place for that period of time and people are staying at home, the risk of sort of carrying something on for more than that period of time is very low.
Okay. Yeah, and a related question we had is about any updates to quarantine guidance. And then if people do get tested, I know there have been varying reports about lag time in test results. So perhaps you can speak to those.
Well, I think the lag time is really a more of a national issue with shortage of reagents. And the fact that we've escalated the number of tests that we've been doing, so it is a problem that we're facing, and I think that most people believe as time goes on that we'll catch up and have a quicker turnaround time. There's I think internally in the One Brooklyn health system, we're generally getting test results back in a couple of days. The hope is that it can set up a process to get test results back in a few hours at some point in the near future, because it does help out a lot to have that information very quickly. An area where this comes up a lot is in bringing people back for needed and deferred care, like an elective procedure. So imagine somebody who needs an elderly patient who has a cataract, and the cataract's bothersome, affecting their quality of life, affecting their vision. It's certainly something that has to be addressed for lots of reasons. But the protocol is always that we test in advance, and we have to know the result of that test within 5 days of the actual procedure, part of our safety program. So a quick turnaround is very important to how we deliver care to people of all ages.
Okay, yeah, that's helpful. And I think we have two more doctors to speak. Dr. Viswanathan, perhaps you can give your overview of your practice area, and then Dr. Hershberger.
Dr. V, I think you're muted.
you hear me?
There you go, yes.
So Jackie had said we should introduce ourselves. So I'm the chair of pediatrics at Brookdale Hospital, and I have been on the staff of Brookdale as a faculty member. It'll be 34 years, end of this month. August 1st was 1986 is when I joined as a faculty member. I'm basically a pediatric hematologist oncologist. So I'm going to talk about, everyone has spoken beautifully about, the impact, and it was so, it was literally a history of what happened even at Brookdale's ER and what happened at, our institutions, as happened at our sister institutions. So I'll talk a little bit about the pediatric experience. The one thing we noticed was that as Dr. Cheng alluded to, our pediatric admission, ER visits, literally went down. Just 1 second, someone's knocking. Can you hold on? Went down so much that we found that instead of, we usually get about 25,000 pediatric ER visits a year, and this really crashed down to maybe 5 to 10 visits in a day, and that was a little bit of a shock. But as Dr. Cheng mentioned, people were avoiding the emergency room. So, of course, our concern with pediatrics is not just, are these kids who are sicker staying at home? So we kind of, one of the things we did was we tried to do a lot of telehealth, and the reaction was mixed in the sense, for the most part, patients really liked it. Even for my pediatric residents, it was a great experience because when they called the patients at home and spoke to the families actually felt very good. And of course, different from what Dr. Bhandari said, here the patients were way more savvy than their parents in terms of doing telehealth or video help. And but obviously there are certain things that you cannot do. You cannot do a thorough exam, and you cannot get blood tests and or follow up certain things. But for the most part, there were certain chronic conditions or medications that you can really talk to them about, and you found that you could spend that time without a lot of interruption. The things that concerned us now that the COVID, the influx of patients has gone down, is you want to be sure that these children get immunized and get those immunizations that they may have missed. So that's one thing we are concentrating on now. In terms of COVID, sometime around April, we started to get reports that there were these unusual presenting findings, very similar to Kawasaki's disease, where children were presenting with what ultimately got called multi-system inflammatory syndrome in children, which is also known as MISC. And we, in the Department of Pediatrics, were sure from the very beginning, from the time, sometime towards mid or end of March, we had almost every week 2 or 3 conferences very much related to COVID, its presentations, so that everyone in the department was really up to date with everything almost on a daily basis. In addition to continuing our educational activities, we concentrated on COVID. But when MISC came about, we called in a group. We had a group of our pediatric ID, pediatric cardiology, the hospitalist, the intensivist, and the emergency room people, and we got together and really came up with an algorithm that we could use for children who come to the pediatric ER with conditions where you should start suspecting MISC. And it so happened that the very next week, the state said that you have to report suspected MISC to the Department of Health. So we were very, we felt we were very proactive and kept this in mind when patients came in. So we were really checking their D-dimers or, whatever the tests were that we felt was very important. And we did report some cases to the Department of Health, and then the DOH does its own investigations. So we contributed to that, and our patients did well, but the numbers of inpatient numbers in pediatrics definitely went down, and they are starting to pick up now. And I hope, and we do feel that patients are starting to come back. And we do want to reassure the public and people who use our institutions that we do have clear-cut guidelines in place for to maintain social distancing. In fact, I ended up needing to go to a clinic today for my own self, and I was amazed at the amount of social distancing that they had in place. This was in an adult clinic, orthopedics actually, to be clear. And I was very impressed with the way that they followed the rules. And I think One Brooklyn Health, I also have to mention that throughout the crisis, we had safety meetings which occur almost on a daily basis every morning at 7:45. This continued throughout the crisis, even through the weekend. And every one of us who were part of the calling in group, we were kept up to date, including things like, do we have PPEs available and how much is there? Do we have enough for the next 3 days? And how many vents are available? And I felt that everyone was kept involved. And I also, what was remarkable was the incredible cooperation between 3 institutions. I knew that when we ran out of, I think it was shields or masks, or, we got a shipment from Interfaith, and I was very impressed with that kind of cooperation. I thought we really worked amazingly well as a group, and I'm sure Jackie can attest to that, because I saw it in, while it was going on. So going forward, we are cautious, and we are very careful, and we value our patients, and we want them to know that we care for them, and we want them to come back, and we will give them the best care possible, and continue the good work that One Brooklyn Health does.
Yeah, thank you very much for the overview. I know last week we had a couple doctors on speaking also about pediatric services and the importance of routine vaccinations as kids and families think about potentially returning to in-person school environments, and to just keep up with vaccination rates that have fallen woefully behind what seem to be normal levels. So thank you for emphasizing that. And then lastly, I believe, Dr. Hershberger, do you want to give an overview of your practice area and how it's affected, what you're up to?
Well, I guess I've been at, I'm Dr. Jason Hershberger. I'm the Director of Psychiatry at Brookdale and at Interfaith. And I'm responsible for the system's response to the emotional needs and the mental health needs of patients and staff who went through this really difficult time. And I'd say that from my experience, when the infectious disease thing part of the pandemic was peaking, it's really the other doctors here, it's Dr. Chung and Dr. Viss and Dr. Bandari and Dr. Krodoff, that were real heroes that stepped up and took care of patients in crisis at no small risk to themselves. I guess the behavioral health department saw our role as supporting these heroes through that time. And supporting our patients through that time. I'm humbled to speak after Dr. Viss, who's 34 years in the system. I've only done 7, so I feel like a rookie still. But it's really an incredible group of professionals that gave everything to keep the people of Brooklyn healthy and safe. And treated during a very, very difficult time when we took an incredible hit from this pandemic. I would say that in behavioral health, the 2 areas in which we pivoted to do something different during this time in response was, one is we moved towards telemental services or telehealth services. So traditionally, behavioral health services, whether that was for addictions or depression or anxiety or other mental conditions, was in person. So people would come to our clinics. We'd see about 5,000 people just between Interfaith and Brookdale, 5,000 visits per month of people coming to our clinics for care and treatment. Very quickly, we embraced what we're doing right now. We embraced video technology. We embraced work where we're connecting to people not in our offices, but in their homes through the telephone, through Zoom, through FaceTime, through these sort of video connections, which was an incredible transition that we did in a week and a half. We went from everyone came in to everyone stay home, stay off the streets, stay out of the subways, isolate, quarantine, but still we're still there for you during this time where there's incredible emotional stresses with all the anxiety that everyone was feeling, the fear, the grief sometimes that people were going through. So I was really, really proud of how the behavioral health department was able to manage this transition from in-person visits to this embraced brand new technology thrust upon us by the necessity of the moment to keep people safe, but still deliver a service that help people through hard times. So I'd say that was the first major change in our practice. The second one really is a turning inward towards making sure that healthcare professionals like the four doctors that just presented are cared for, that their emotional needs are met, that their stress level is manageable. This was a time of incredible stress for everyone and trauma for some. And so being there, providing support for healthcare professionals who really went above and beyond the call of duty during this time is one of our core missions. So we've been doing a lot of group meetings, individual meetings, hosting groups like this, mindfulness sessions, empathy circles. We've even partnered with the U.S. military to bring back sort of disaster relief and trauma support for people who've been on the front line of something really intense and really scary. So the way disasters work is that there's usually some terrible thing like a pandemic peak that the world gets through, but afterwards there is a steady peak of mental distress. There's a growth in anxiety symptoms, trauma symptoms, depressive symptoms in our healthcare workers and in the community at large. So I was really proud that our departments were able to continue and frankly expand our reach to Brooklynites who need us. So we are still available to folks that are struggling with emotional distress, mental distress, addictions during this time and in the aftermath. And we're open for business, and we're doing most of our care remotely through this kind of vehicle, so we can still connect with people and support them and keep them safe.
Thank you very much. Yeah, and I know this has been an emphasis along with just overall health and the importance of lifestyle habits, healthy eating, and sleep and mindfulness and meditation, other things the Borough President has emphasized during this period and for many years. And maybe you could just speak about if you have any tips or things that people or families could do. I know there was a period of kind of shelter in place, which was a heavier isolation period. There's a little bit of more reopening where you can go out, perhaps do some light outdoor dining or be a little more free in some public areas. So maybe you could talk about if there are things within family systems or in these types of things that you would advise to just kind of check in with folks' mental health. And then if there are kids of different ages, if you have any guidance for them. I know it's a period of uncertainty for adults and kids, sort of what will happen next, what will the new guidance be, what can I go play sports in the park or not, and those things are fluid things which can create some stress for people of all ages. So I don't know if you have any top lines or things you could share with constituents on those issues.
Well, I guess I could say something general, just like a general principle, and that's, we are all living under some constraint. Whether we can go out, whether we can work. We're dealing with economic stresses, personal stresses, family stresses. Sometimes we're suffering from isolation because we can't connect physically with people the way we used to. Sometimes we're suffering from compression, where we're all living on top of each other and no one can leave. And that creates a lot of tension in family systems. So I think the first step is to be honest with yourself that this is a stressful time, and that there are constraints that we have to accept and have to be able to manage. And then in those constraints, still finding some way to care for ourselves. Now, self-care can take many, many, many forms. And I think, there are lots of general advice, like, calming breathing exercises, or, doing, things like healthy, like make sure you sleep well, make sure you don't drink or use drugs, sort of basic, sort of commonsensical things. But I think a deeper message is that we all have something that means self-care, and it's really individual. It could be, playing a board game. It could be painting your nails. It could be a myriad of other things, reading books. Each of us has our own thing that means that if we do it, we're taking care of ourselves. And the act of spending a moment to care for yourself and to care for your loved one in some deeply personal, emotional way is really, really helpful. So that's one thing, is make sure that self-care becomes a routine, because under all these constraints and all this circumstances, a lot of us were either constrained from our ability to interact, or we were working so hard that we forgot about ourselves. Make sure that self-care is part of it, because unless you care for yourself, you're unable to care for your friends, family, or patients. So that's one thing. I'd say the other global thing that comes to mind is that each of us needs to slow down. The more we can slow down, pace this out, not rush to make changes, not rush to solve things, allow the world to heal, and we can catch up to it. Everything is still going to be there once we're more through this than we are right now. And the more patient we can be, the better. The more we can wait together, the better. So patience and self-care, they're commonsensical, they're kind of folksy pieces of advice. But sometimes under stress, actually especially under stress, people forget the basics. They forget to pause, that it's temporary, and that they can care for themselves even now in some small way that could be symbolically really important.
Thank you. Yeah, those are, I think important things to keep in mind, and helpful for people and families. And as you said, the isolation and compression and some of these types of things that people are dealing with as they adapt their environments, but keeping in mind to try to take care of ourselves as an initial step, or check in along the way. I wanted to get to a couple questions we had come through. One, I'll just open it up to the panel. Is what do we now know about coronavirus antibodies, and what if there is an immunity life, or what we understand based on those things with testing in New York City, and then just where we are with what we know about that. So I'll open that up to anybody who wants to comment on kind of the state of affairs on antibodies.
Well, I can just comment on that. I think what we know is that after about maybe 10 to 20 days after being infected, most people produce antibodies that we can measure in the blood. And there's a prevailing belief that those antibodies do provide some immunity. Whether it's absolute immunity and whether it's permanent immunity, I don't think the disease has been around long enough to know the answer to that. So we don't advise people who have been exposed and have had the illness and have the antibodies that they can take off their masks and relax all the precautions that somebody who has not been exposed has to take. We still recommend that the social distancing and the masking and using a lot of hand sanitizer should be continued, even if you have the antibodies that we measure, only because we just don't know enough about this disease to relax those general standards. But most people, the vast majority who do get exposed will produce antibodies, which represents at least some partial immunity in most cases. And that seems to be the prevailing wisdom. It is the essence of a vaccine. In fact, when vaccines are studied, part of the way they're studied, in the beginning, is to measure whether you produce the antibody that you'd produce naturally if you actually had the illness. And we know that from the vaccine research that people do produce antibodies when exposed.
Oh, okay. Yeah, that's helpful to understand. I know these are the research and the literature is evolving. Maybe you could talk too. I know there's been some international research pieces written, but just on the topic of reinfection, what do we understand as to whether it's possible to be reinfected with COVID-19 at this time? It seemed like there was some conflicting literature as to whether that was feasible or not.
I mean, I can tell you what I know, and it's a very controversial area. There are case reports of people that circulate in the literature where there's a concern about a reinfection, but it's very difficult to know whether that's a true reinfection or not. It's a controversy, and I think it's a good question for the virology experts at the NIH to answer. The reason it's so tricky is that a lot of the way we monitor for an infection is by doing a nasal swab. And what the nasal swab does is it picks up pieces of DNA that would be from the virus. And it's very, very specific to the virus. What we've learned is that some people have this DNA in their nose a pretty long time after they've been infected. And yet a lot of people are just no longer sick, and they no longer can be transmitted to anybody else. So the controversy is whether people who have this, are they being reinfected, or are they just having some shedding from a long time ago? It's a very difficult question to answer, and I think the NIH and the CDC is wrestling with exactly that question. The question of reinfection remains something that is being thought about and really studied.
Yeah. I know there's continued news reports about vaccine development or therapeutics. So sort of continuing to evolve on what we know as things proceed. One other question we had was exactly how to undergo a quarantine. So let's say somebody had a positive diagnostic test for COVID-19. I don't know if the doctors can perhaps talk through a few scenarios. If you need to go through a 14-day quarantine, and if you're in, let's say, a multi-generation family household, or it's easier, I suppose, if you lived alone or had various rooms in an apartment or a home. But maybe you can offer guidance on how exactly someone would go about that based on what the protocols are, and then just given the density of living environments in New York City, which can pose a challenge for creating space from your household members.
I could.
Yeah, do you want to take that, Dr.
Kick it off.
Yeah.
I think You know, the essence of the quarantine is staying in place in your house, and the social distancing, which means staying 6 feet apart, wearing a mask, hand sanitizer, wiping down surfaces in your home with household cleaners to protect the general environment, and riding out those 14 days. You know, we have sort of literature that we hand to people who are not sick but may be exposed more commonly in April and March, when there was a lot more coronavirus in New York. Fortunately, in contrast to the rest of the country, where we don't have as many cases, we do have some, but certainly not like it was in the beginning of April, or what's going on in Florida, Texas, Louisiana, Nevada, and some other places. But the essence is really the social distancing techniques and the sanitation of the environment, and for the quarantine.
Yeah, okay. One other question. I know we talked a little bit about pre-existing conditions, whether it's diabetes, or if folks are dealing with other conditions, whether children or adults. So maybe across some of the practice areas, if folks have a pre-existing chronic condition, heart disease, type 2 diabetes, or struggling with weight management or obesity, what the guidance is, number one, on how best to engage with your general practitioner or your doctor, and then the other is how to undertake some lifestyle habits that can perhaps, along with the general guidance with hand hygiene and wearing a mask and doing the social distancing, given that those populations, as we've seen, are just at more risk for contracting the virus and for suffering worse outcomes oftentimes. So just on the issue of pre-existing conditions, and then I think that also applies to if folks have mental health conditions that may be pre-existing, whether depression, anxiety, other types of things they may be working through. Yeah, how to manage and engage with your medical practitioner.
I can talk a little bit about diabetes and in that context. I think the one very critical point is to recognize that it is a pre-existing condition for a worse outcome should someone who has, for instance, type 2 diabetes, they were to acquire the coronavirus. So just that one fact, I think, can dictate a certain amount of behavior, meaning that people have to be extremely cautious because they are at increased risk, and we can't sugarcoat that in any way. That people who have heart disease, hypertension, diabetes, and obesity are increased risk for more severe disease and have to take really extra precautions with the social distancing. It is a good time to do everything possible to control those pre-existing conditions. So to pay attention to control hypertension, diabetes, where possible, to have healthy amounts of exercise, which is a double challenge during sheltering in place, but there's ways to do it. I think our borough president is really an expert and a lead on how powerful healthy foods can be for treating underlying illness. So while people may be sheltering in place, there is a great need to focus on eating fresh fruits and vegetables, nuts, seeds, legumes and beans, and maintaining a healthy weight to reduce the likelihood of having severe disease should there be an unfortunate exposure. So I think Dr. Bhandari spoke a lot and so did Dr. Viswanathan, about the power of telemedicine. There's a lot of opportunities for people with those illnesses to receive their, 90% of their health care, including behavioral health, without having to go to a visit actually in the institution, especially for chronic disease. Acute disease is a whole different story. But it would mean having the ability to check your blood pressure, your blood sugar, and your weight at home, and having a expert consultation from your healthcare provider. I'll stop there because there's a lot to this question, and I know other people are going to have a lot to say also.
Yeah, Dr. Bandari, did you want to
I just
comment as well?
Correct. So I just want to add on to what Dr. Kodroff was saying. For the people in the community who are listening to this, should take advantage of the CMS-run program. There's multiple program on chronic care management, which came into play back in, I believe, 2015 or 2016. And there are a few programs which is supported by CMS, not a cost. It's not an out-of-pocket cost for the patients. Remote patient monitoring program, which allows them to own the devices, meaning paid by the CMS for blood pressure, glucometer, weighing scale, and pulse ox. And the technology currently that we have pushes that information as real-time data to a provider, where the previous practice of retrospective look of how the chronic care was managed to a more of real-time and prospective approach of managing this chronic care would be an extremely crucial movement to forward. Dr. Kodroff can definitely talk about his diabetic patients, where he's managing his diabetics, when he's looking at a specific blood test called hemoglobin A1C, and it's a 3 months retrospective look on how the sugar was controlled. So instead of looking retrospectively, I think patients in the community should take advantage of all the 3 programs which is supported by CMS. One is annual wellness program, which really is a comprehensive look on, especially for seniors, I'm talking about, risk of falls, cognitive decline, mental health, and chronic care management, specifically if you have a senior who have more than 2 diagnoses and who've seen this provider for the last 6 months, and remote patient monitoring program, which covers blood pressure, diabetes, obesity, COPD, asthma management. I think it would be, it's a real partnership between a health system and the community if we both take advantage of it.
Thank you very much. Yeah, and those are programs through the Centers for Medicare and Medicaid, correct?
That's correct.
Correct, okay. Yeah, Dr. Hershberger and Dr. Vis, do you have anything else you want to add as far as just pre-existing conditions related to your areas?
Sure. Well, in behavioral health, we actually looked at that at Interfaith, and we tried to determine whether our behavioral health patients were at greater risk than our non-behavioral health patients in the system, and we couldn't see a difference. So having a behavioral health disorder itself doesn't seem to be a risk for COVID infection in our experience. However, from my perspective, there are a lot of pre-existing conditions in the behavioral health world that, under the stress of COVID, get worse. So the one I'm particularly concerned about is depression. People that have a history of depression can get depressed again under the stress of the isolation of COVID, and people who have struggled with addictions. So sometimes if you had a history of an addiction, even if you've been in long-term recovery, going through this kind of stress puts you at a risk of relapse. So my recommendation to patients with a behavioral health history of any kind is reconnect with treatment. Reconnect with a 12-step group, if that's whatever got you well in the first place. Go back to it for a booster shot or for a check-in, even if you're feeling fine, just to ward off a return of something that could be problematic.
Thank you for noting that. Yeah, I know addiction of different types has been something that has come up in the literature as programs have adapted and 12-step programs have gone to Zoom meetings and can no longer meet in person, and the social engagement and social support in person has affected those groups along with the general population in significant ways. So thank you for raising that. Yeah, Dr. Viss and Dr. Chang, I don't know if you have anything else on the pre-existing conditions. And then just as far as the time check, we have 10 or so minutes left. So after this, I'll check in with our team, Mike and Glenda, if there are any additional questions in the chat that you want to raise. Otherwise, we can come to some concluding comments. So, yeah.
Certainly, children who have pre-existing conditions or chronic illnesses, it has had an impact, and we don't have the exact numbers yet of reports from different places, but certainly we've seen that in our population of sickle cell patients, the fear has been, they've been reluctant to come in, even for regular checkups, or even if they have a painful crisis. It's so much, it's scary for them to come. It was scary for them to come into the hospital, and now they have started to come back, and they did maintain communication, but were not interested in coming in for therapies, including transfusions if they needed regular transfusions. And there was also this fear that there would not be enough of a blood supply, but that did not pan out. Luckily, we were able to transfuse patients who needed transfusions and with sickle cell disease. We also had, now we are facing with a situation where actually the families called up because we have a regular monthly support group, and they wanted to know when we can have that again, because they really want to connect again with each other and with us as a group. But in terms of COVID itself, actually from the very beginning, and even it was almost a weekly call. We had I was part of an international every Friday afternoon call with sickle cell physicians, sickle cell and thalassemia physicians from all over the world. So sometime in the end of March and early April, we started to learn from our Italian colleagues, depending on, based on their experience with what was happening to those patients. So we really were very proactive in the sense that when sickle cell patients came in and they were pediatric patients, we knew that they were more prone to coagulation, clotting. And so we would be a little more careful with them and actually proactive. And these meetings continued, and only today they've decided that we'll do this meeting once a month, but it became once in 2 weeks. And we really, we had data that we were submitting and from the United States, which recently also got published. And we had data from London, and we had, so really there was this incredible international collaboration that we were part of, because I was participating in every Friday afternoon call. So I kept up on that, but even otherwise, there are other, we've seen an uptick in the number of patients coming in with new onset diabetes, even in children. So this is, I have to look at the numbers, and we have to see what the national statewide numbers are, but certainly the coronavirus has done things, has had people come in with presentations that we did not even expect. And with children, it's always something, it seemed to lag behind the adults. And so we are holding our breath, and, we're just making sure we are very careful. We continue to be careful because we're not out of the woods yet. We believe we need to continue to be careful.
Yeah. And then any final notes, Dr. Chang, on the what you see in the ED as far as pre-existing conditions?
So I just want to add a little bit on to what Dr. Hershberger said. Obviously, if you want to get to a top of a flight of stairs, the first thing to do is to take the first step. And because of the coronavirus and the pandemic and how it was shown on TV, and it was scary, fear is a big factor in how a lot of our patients are not making that first step. And, Jason have already said that, listen, there is a lot of opportunities for these patients to be able to be treated and not having to even come to the emergency department, which included, telemedicine, which included calling your personal provider, and even going to the urgent care. And so, for me, it's almost like, listen, if you have some symptoms and you have a lot of multiple comorbidities, you should really seek medical attention. And when you do, that 99% of the time, you're not coming to the emergency department, and many of the times you will feel better because now you're actually, you feel like, wow, actually, my worries are gone. But for that 1% of patients that don't seek medical attention, those are the ones we worry about. Those are the ones that have a stroke. Those are the ones that have an MI. Those are the ones that, have a ruptured appendix that really needed immediate attention. And those are the ones that we worry about because those are the ones that have really bad outcomes. So I think that, the general consensus is really like, listen, coronavirus is scary. We understand it. But, take care of yourself and really look. And when you do have symptoms, seek medical attention. And if you do need to come to the emergency department, at that 1%, we're here for you and it's safe.
Thank you very much. Yeah, for those notes that are critically important, and to just reemphasize. And I know the Borough President has been in contact with facilities across Brooklyn to understand the new safety protocols for folks to return safely to in-person service, to get care for things that they may have had a care lapse on, or if they do have an emergency, when, how, and the navigation of those sorts of things. So I wanted to turn to Mike and Glenda and Eileen, and then recognize Lori Lewis from our team here at Borough Hall to just wind up if there are any additional questions in the chat that we may have missed. And then also, we can circulate briefly for some final remarks before we close here shortly. So I don't know if we have additional questions in the chat or other questions.
We got to all the questions that came through the chat.
Great. Lori, Glenda, did you have any questions or things you want to add?
I want to thank all the doctors from One Brooklyn Health for participating this afternoon. We've been just getting a lot of questions from our constituents around their fear for going into a doctor's office and sitting and waiting in a doctor's office, and how can they get answers to questions. So that's why we put these sessions together. I wish they were a little better attended. I don't know, maybe this isn't a good time for people, but I do think that the information we have and the fact that we're recording these, we'll be able to play it back and people can see it. And I just thank you for your time.
Yeah, thank you so much. And before we close, I wanted to also recognize again Jackie Knowles and Enid Dillard from One Brooklyn, and then Sheila, who's also with us. So thank you all so much for putting together the group today as well, and for your partnership with the office. And then for the doctors, any final notes on things that you want to share with constituents before we close? And I think, as Lori mentioned, even though the audience is perhaps small, we will try to circulate online so folks can utilize this recording and the questions answered as a good resource on a number of topics that we've covered. So yeah, I'll turn it over to the doctors if you have anything you'd like to add.
The thing I would like to add is that people have to wear masks, and we need to make sure we wear our mask all the time. But I think we need to encourage the public to wear a mask, every time. And it's very bothersome when you're driving down the street or walking and you find people not wearing a mask. And I think we really, that's really important, because in a sense, coronavirus, we worry that we could have another surge, maybe not as bad as before, but we want to prevent a surge. And I guess the only thing we can say is wear a mask and wash your hands.
This is Dr. Chung. I just want to say that during the peak of the coronavirus, our staff was really appreciative of the community and what they did for us in terms of bringing in food for us, and also, trying to find some way of getting us PPE. And that was very, very important for us to feel like we were loved, even though we were in the midst of trying to save a lot of people in the community. And I just want you guys to bring it back to them and say, hey, listen, we really appreciated what you guys have done for us during that period of time. Our staff was so happy when we're in the middle of a 12-hour shift and we're in the PPE, all dressed, all gowned up in the PPE, and we really didn't want to leave, to know that, hey, you know what, you don't have to leave that far, that there's food already here, you don't have to worry about that, just eat and take care of your patients. We were so happy. So just let everybody know we were very thankful about that.
Thank you so much for that. I know, Lori's team, Glenda, Mike, Eileen, and a number of other folks who aren't on the call today here from Borough Hall worked really hard and continue to do so to try to support you. So really appreciate those comments and feedback. Yeah. Any other comments from the doctors?
I'd just like to add, I think it's been echoed already, that we're here for the community, and there's no patient that cannot get care either in person or remotely for any condition. So we're here for the entire community, and we can provide access. And then lastly, that all pandemics end. This pandemic eventually will end. And we'll look forward to that day, but it will end at some point.
Yeah.
That's what we're all hoping for. We're all hoping that it ends, we get out of this safely, that you all get out of it safely. We thank all of you for your time and service, because I know the last couple of months have been really difficult for you. So we do thank you.
Yeah, thank you so much. Yeah, so with that, unless we have other comments from the doctors, Glenda, do you have anything else you want to add before we close?
No, Nate, thank you so much for moderating, and doctors, thank you all for just providing some very helpful, informative information for all of us. So thank you.
Great. Yeah, well, thanks so much.
Okay, so I guess I will formally adjourn our meeting here today. And again, just thank you all, doctors. Please continue to be well and keep safe. And we hope to be in touch for another event such as this. So thank you.
Thank you.
Thank you for inviting us.
Take care.
Thank you, guys.
Thank you so much. Yeah, appreciate everyone.